Hello everyone, I'm Yuan and welcome to my channel of Lighthouse Pharmacology. So in this video, we'll actually be going through a very niche or specific topic on the bioequivalence study, which is actually on the design of the study itself. So there's a lot of criteria that we need to consider when we design a study. So among two of them, which is on the standardization and also the sampling, which is what we're going to cover in this video. So we're going to go through a little bit about why we need to do this. So we'll be seeing a lot of guidelines which comes in, and also how to do it, to implement it actually from the guidelines. So as you can see, everyone is different actually. All right, so how do we actually try to standardize as much as possible to ensure that everyone, if they're in the study, when they take the same tablet, will actually get a similar profile of your pharmacokinetic profile that you actually be getting, so that you can actually achieve the criteria of bioequivalence from your ultimate calculation later on. And bear in mind, the studies cannot be repeated based on what you need, so the design of the study has to be done very carefully and meticulously since the start, so that to allow the whole thing to flow through properly without hiccups. So sampling on the second part, which is on the sampling of blood samples, of course. So this is how you actually need to plan when to take your samples, right? So before we need to do a BE study, so the first thing that we need to ask is actually whether do we need to actually do the BE study. So it depends on the product that we are looking at. So this is all dictated in the documents. So in this case, I'm from Malaysia. We're from Malaysia, so it's actually registered under the Drug Registration Guidance Document (DRGD), and this is the 2022 version, because every year they will actually release a new version with some minor corrections here and there. So if you're from different countries, you realize that the principle of conducting or planning a BE study is actually quite similar, but it's just that there'll be some minor differences between different countries' guideline, which later on we'll look through at a later part of the video as well. Right, so the principle will still be the same, right? So here, for BE studies or bioequivalence studies, it has to be a product that contains approved active substance, as we can see here. Right, so if it contains something which is a new chemical entity, so they actually have to go through a different drug registration route, which is on the new drug registration process, which has nothing to do with BE, right? So when we look at the list, there are a few stated categories of drugs which you must do a BE study to allow it to be registered for the generic drug in the country, so like in Malaysia or other places. So the first one is the standard one, the historical standard oral dosage form, which is an immediate release form. So second is on the modified release, so you actually have to make sure the profile is similar. Next is on the fixed dose combination, because sometimes and it's getting more and more popular, whereby they'll actually mix two active ingredients into a tablet, so that when the person takes a tablet, they actually get two drugs into it, so it increases the compliance. And the fourth category here is all the more newer form of drug delivery formats, even though it's oral drugs, so it can be effervescence, dispersible, oral dispersible, sublingual, buccal, and also chewable dosage forms. So it's getting, the coverage of BE studies is getting wider, but bear in mind that you can realize that there's a lot of exceptions in a way, like if it's an oral solution, it's actually out of the list, or parental, or eye drops, and so on. So bear in mind, when we look at these four main categories, it's all oral dosage form. So it then links to the second part of this video, whereby we'll talk about the standardization. So you realize that the standardization that you need to make is mainly related to the GI tract, possible changes and influence, such as the food and also the water intake, right? Or medication intake. So now let's look at the overall workflow of the BE study. So there'll be some pre-study evaluation of the screening phase. So you actually have a whole list of the possible participants who are willing to join, right? Then from the list, you can actually enroll them or not, so based on the inclusion or exclusion criteria. Right, so from there, and bear in mind in the earlier class conducted by my colleague, so we realized that you actually need to get in more subjects just in case there's any hiccups on that day, which we'll talk about later on as well. So on the admission day, so they'll be coming in a day before, as later on we'll mention as well, because they have to be, you want to make sure the factor of the food which is taken the night before does not have much influence on the different parameters that you're going to look at. So, and you've got the drug dosing, the different sampling time, which is going to cover in this will be covered in this video as well, and you've got the analysis stuff and the report writing. So you can see it's actually a one-way, as mentioned in the first slide, so there's no reversing. So you actually have to plan very, very carefully and to make sure that no matter what hiccups occur, there'll still be a statistically sufficient number of subjects and so on to cover the whole study to give you the results that you probably expect, which is BE, right? Okay, so you can see that there's a few parts that the variation can occur, which includes the subjects, because obviously everyone is different. So the metabolism rate and so on, there will be some slight variation around. So we try to standardize the gender or the age and or the rate and or the age. If there's a certain disease condition that you need to include in, so you have to try to match them up as much as possible. And we've got the standardization, which is mainly on the food stuff, things which are on the day that we're going to talk about, the sampling, washout, and other characteristics to be investigated. So the characteristics here that we talk about and washout period and so on, it depends on the characteristic of the drug per se, because obviously every drug is different. Some it can be metabolized into a prodrug, or sometimes you actually have to measure the metabolites as well together with the parent drug. And obviously the washout period will be different and so on and so forth, so that will affect your sampling time. So taking all this into consideration, there's one thing that you need to take home message about is on the tailor-made of the protocol based on the drug they're actually looking at. Right, so it's a very specific form, but don't be too worried in a way, because there's a lot of drugs which are being studied very well already, so there's a lot of published articles on it. So before you actually conduct a study, so the first thing that you need to do in a way is actually to look up in PubMed and so on to find out what other people have been done, so you roughly get an idea on how the time frame and analysis method should be. Okay, using another slide here to illustrate, right, the different sections of the BE studies. So we've got some variables as mentioned just now, which we want to standardize, right, which include your health conditions that we try to standardize. We've got your standardized diet and fluid intake, which we're going to elaborate much more in the next slides. So in this first part of the video, in a way, the first section, because it's mainly divided into two sections, standardization and sampling. For standardization, the main aim of it is to minimize the variability between individuals. So we try to equate them, right? So we realized that it's about at least a minimum of 12 subjects that we need to recruit per study in a way, but we normally recruit more, so to enable that in case someone didn't turn up on that day and so on, so there'll still be sufficient at least 12 subjects, right, who can actually participate the study from the start till the end, right? So you can get all the time points and drug concentration measurements that you require, right? So we try to standardize things. So touch wood, if the variability is high, because there are some cases, maybe as we say, when we do our screening, we don't actually screen their liver profile enzymes to know whether they are fast metabolizers and so on. So in case there's some anomaly, so we actually need to justify and so on, right? So we try to make sure that the study is as smooth one as possible, because again, it's something that includes the costing as well. In Malaysia, where we are in, ding, ding, ding. So we mainly refer to the ASEAN guidelines, right? There's also some harmonization of ASEAN guidelines between the BE centers as well, upcoming, so it's still quite a revolving field. But in general, we actually look at this guideline. So as mentioned earlier on, the three main variables that we're trying to standardize is first is on food, which actually includes what you drink, right? And also includes your supplements and so on, medication as well. Another one is on the posture, right? So because we normally conduct the BE study in a clinical setting based on the ethics requirement, we need AD, the defibrillator, just in case we don't know if a participant is actually hyperallergic to the drug that he or she is taking. So it has to be in a clinical setting. So, and it's like a ward setting-ish because there's phlebotomies, you need to draw blood and so on. So most of the time for posture, it's mainly just sitting down or lying down on the bed because there's not much space available anyway. So, but it's actually not a very long study. So yeah, you can use iPad and so on to kill time. When we look at the Malaysian guideline for BE studies, so this is actually quite similar across different countries, as later we're going to look at the details, but most of the points are actually quite similar. It's mentioned that standardization of the diet, fluid intake and exercise and posture is recommended, as mentioned earlier on. And there's this point here that the subjects should be at the fasting mode, at least during the night prior to administration of the products. So to ensure this to occur, we'll normally try to recruit the participants on a Friday night because later on when we look at the later part of the guideline, so the maximum time that you need to monitor for a drug for a BE study is 72 hours, which is about 3 days. So most of the drug is actually around 48 hours. So what happened is that in the Malaysia setting, we normally do it over the weekend because where most of the people are available, I mean, for the participants. So we'll ask them to be in on a Friday night after they have their dinner, right? So we can make sure that the fasting is standardized throughout all the participants. So therefore we can tick on the box. So when you look at the guideline, it's like a checklist actually that we need to present the evidence in the final BE report, whereby there's all this small stuff that hopefully you can tick off one by one to make sure and to show proof that standardization of the study is actually being done. Right, so when we look at it, so at the next point, when the reference product, which is the drug per se, or the test drug, the generic one, or the reference product, most of the time is administered with food or without food, so it depends on the scenario. So whether yes or no, there'll be a standardized meal at a specified time, so everyone will be eating at the same time, right? So to make sure that when we swallow the tablet, for example, you have to specify the volume of fluid intake. So this is like a cup of water, you know, whereby everyone has to finish it up. And all the meals and fluid taken after the treatment. So because obviously they can't be starved for 48 hours, so there'll be meals in between and so on. It has to be standardized. So to allow this particular tick box to be ticked off, so you realize that you actually need the participation and involvement of dietitians because they are the expert in calculating the meal content, like the calories and so on. Okay, and there's another part here on the second paragraph which states that all drinks such as alcoholic, xanthine, contain beverages like your coffee and stuff, or tea, and certain fruit juice like grapefruit juice is something a big no-no in a way because they're prone to have some interaction with the drug they're taking, right? When we look at the rationale, right, of why we need to actually standardize the food intake, because it can have different effects on the GI transit time. So when there's different changes in the transit time or on the metabolism and so on, so it can affect the absorption rate of the drug and therefore the pharmacokinetic profile that we need to measure. Right, so these are the physiological explanation for it. So it delays gastric emptying. So if someone eats more, if someone eats lesser, you know, or someone is eating some food which is more oily, right? Some which are more on the vegetarian type of diet and so on. So it changes the pH, changes the amount of bile secretion, right? That changes the metabolism or any interaction as well. Right, so therefore, the nutrition and the calorie content of the meal, so the volume of the meal as well, right? Because remember the amount as well, right? And the meal temperature can cause changes, right? So which is what we try to avoid, right? Because there's already a lot of individual differences and variability in terms of the metabolism rate, which we can't actually exclude out of the topic. So the other type of factors is what we try to control. So you can see the meal volume. So imagine the dietitian that we mentioned, he or she actually need to weigh the amount, the portion of the food as well. So it's actually quite meticulous, as you can see here. Next, we'll look at the medication intake, so which is one of the major factors that could influence your results, right? Due to drug-drug interactions, whether their interaction is in the GI tract during the absorption phase, or it could be interaction during the liver metabolism phase, right? So in general, we'll try to say no. That's the general rule, because to exclude it, it actually excludes a lot of hassle in terms of the analysis as well, right? So we try to avoid it most of the time, and this includes any herbals and supplements as well during that study phase, which is, say, probably 48 hours or 72 hours. So no coffee or tea, just water. If the subject is unwell on that day, so before the medication is taken for the test drug for the BE study, if it's the person is feeling unwell, the easy decision is normally we just withdraw the subject. So we ask the replacement to come in ASAP, right? So that's the easiest way, because in case it's also unethical, isn't it? If the person is having fever or flu or cough, I'm just using the minor ones as an example, but then we can say because you're in the study, so you cannot take the medication that the person needs, so it's unethical. So if there's any drug taken on that day after taking the test drug, so maybe some person feels certain side effects, but the others didn't, so we actually need to write down what drug the person has taken in his or her notes, right? At what time, what dose, how many times the additional drug has been taken, because all this need to be later on we need to evaluate if this other drug can actually interfere with your analysis method, right? So we have to take note first, just in case. We can still use the data. If not, we might need to just exclude the data altogether, right? So in some rare cases whereby the drugs that we look at, we need to actually give some drugs to tackle the side effects, so that will be given to all the participants due to safety or tolerability issues, right? So these are things maybe anti-cancer drug, for example, that we use on cancer patients and things like that. So there's some anomaly, so the extreme example. So for those, we actually need to take note, and we have to analyze and decide whether there's any interference that we get towards the results that we in the end, right? So there's a lot of considerations that we need to take note of. Okay, so this small portion on physical activity is the easiest to be managed in a way. So normally it's limited, as mentioned, because it's done in the clinical setting, so it's in the ward. So they'll normally be resting on the bed, okay, when the intake of food, and water and so on, and when the samples are taking. So in between, they can still walk around and so on, which is fine, but it's not really like an exercise regimen or crash camp that we talk about, right? Okay, in this section, we'll dive deeper into the requirements of the test meal. So most of the time, it's just the normal meals, right? So over here, you can see that there's certain drugs that has specific requirement of high fat, high calorie diet. Right, so this is for certain drugs whereby we realize that the amount of fat in the diet will actually influence the amount of drug absorption. So there are a few anomalies, all right? So what happens is that, so this one, they actually have a higher percentage of calorie, right? So it's the calorie breakdown. So for things that you have to include in the report, so whether it's considered high fat, high calorie diet or the normal diet, so again, all these reports has to be given. So what meal do you give for breakfast, for lunch, for dinner, right? For the 2 days, is there any tea time that you give in between? But bear in mind, there's no coffee and tea, right? And things like that. So everything has to be listed on how heavy, the portion, and so on. So as mentioned earlier on, it's the dietitian's best expertise to provide all this data as well, right? So example of high fat, high calorie meal is something you can see here. So there's eggs fried in butter, there's bacon, there's toast, there's hash brown, there's milk. Ooh. So as long as it hits the calorie requirement, right, it's good enough. In this slide, we'll look at the take-home messages from the guidelines on how we actually translate the points in the guidelines into the different tick box that we can tick off when we implement the study itself. So the first one is that most of the drugs is actually taken in empty stomach, right? Whereby it's actually already mentioned in the guidelines, whereby there's fasting overnight, isn't it? But there's some anomaly examples for the requirement of certain drugs, maybe due to tolerability issues, or it can be due to the fact that it needs to have higher absorption after food intake, right? So therefore, for those certain few rare drugs, it's stated that the drug must be taken after food, right? So there are some tailor-made issues over there. And no matter how, you need a dietitian to be involved to calculate the calorie intake, right, and the nutrition breakdown from all the meals that the person take during the study. So they have to standardize the portion, so which includes the weighing of the food. So the easier way is that you can imagine if there's around 15 subjects in the study, right? So you have to weigh 15 portions of every meal that they take. So whether it's breakfast, lunch, dinner, tea time, obviously without tea, right, or coffee, right, and things like that. So you have to refer all the info in the protocol. So the protocol is, as you can imagine, is very, very extensive, right, which states that what time and when the fellow can eat this, drink this, and so on and so forth. Right, so it's also good that the person you have a small section where you can sign it off. So at this time we serve this, so this is signed. So to show that as a proof that there's traceability of administration, right? So all this will serve as the proof and the supporting documents in the BE report that you need to submit to the authority for approval. So the portion that we prepare is normally not too huge or not too little in a way, so to avoid incidents whereby if the person cannot finish the portion and all, what should we do and all, because we try to make sure everyone has the same portion. Over here, we'll look at the details on the administration of the fasted treatments and also the fat treatments. Right, so no food should be allowed for at least 4 hours post-dose. So you can see the easier way to do it is the fellow comes in overnight for at least 10 hours, right? So you have to drink with some water when they swallow the medication. And so for 4 hours, so we try to administer the drug around maybe 8 o'clock. Then you can start to eat around 12 plus, right? They can start to drink water. If it's given at 8 o'clock, they can start to drink water from 9 o'clock onwards. So all this has to be stated in the protocol very clearly so that you know exactly when you can do what, right? So normally water is only restricted for the first hour of after taking the drug, because you already drink water together with the medication, but after that it's up to you all, right? So standardized meal at the same time, so everyone eats at the same time. And for the fat treatments, you can see that they can start the meal half an hour prior to administration of the drug, right? So you can eat the meal in half an hour or less. So you can see it's a very strict one. So normally in the clinical site, when we conduct the BE study, they actually have a study coordinator, so they'll start to announce everybody to remind people things. Okay, now we have to do this, now we have to do that, so that we won't miss the timing, because when we miss the time, you can see it affects the graph that you need to draw later on, right? So over here, so it's no food should be allowed at least 4 hours post dose as well, and the other requirements is the same for the water. Next, in this section, we'll actually be looking at the variability in some of the requirements between different countries. If you have a quick search in PubMed and so on, you realize that there are some published articles on this that actually compare the requirements of BE between different countries. Some are more nicely summarized in table form, so it's easier to refer to. But bear in mind, all these guidelines, these papers are actually done, it's quite long ago, it's like 2013 and things like when the BE guidelines are initially being developed. So if it's the later ones, if you need to do it, so the later guidelines, the updated one, you actually have to check one by one. So just to show some examples in terms of their variability, so like for fasting requirements, like in Europe, where the EMA guidelines, so it says that the fasting is at least 8 hours prior to administration, 4 hours post-dose, but countries like Japan, Canada, and so on, you need at least 10 hours of fasting. Right, so in ASEAN countries, we mainly follow the European guidelines more closely, so we actually say it's around 8 hours. So for example, if a BE center wants to produce a BE report which can cover all the different countries, so including US, the FDA side, so what they'll do is they'll just standardize just follow the longest one, I guess, so you can just say at least 10 hours, then it hits every criteria here. Okay. In this table, we also summarize the differences between the guidelines in terms of the dosage form that we're looking at, whether it's immediate release or modified release. So no matter which form they are, we actually have to look at the monograph to see what's the requirement, whether it needs to be in fed state or just fasted state will be enough. Right, so what happens over here is that it's the easiest way of conducting a study is the crossover study, single dose. So the single dose, so whether they'll be recruited during the weekend, for example. So weekend in April, so all of them will come in. So they're in that particular week, they'll actually take the test drug or the reference drug, depending on which group they're in. So another 2 weeks maybe, so at the third weekend for April, so they're coming again, so they'll actually take the other dosage form. So the whole concept is that the same person actually takes one time of the reference dose and another time of the test, still not considered generic product yet because it's not registered yet. So the same person taking 2 different drugs under healthy conditions at a different time, of course, because there's some washout period that you need to take into consideration. So hopefully the pharmacokinetic parameters will be similar, right? So some they mentioned that it needs to be in fed state as well, no matter what it says and so on. So you can see sometimes the Japan one is quite strict. Right, so for modified release, so we try to make it there's more variations which could involve because of the modified release, because we know that modified release, it's most of the time the release profile and the maximum absorption will be at the small intestine, which is the later part of the gut. So by the time the drug actually travels all the way there and so on, it takes time and so on. So we normally have to take into account the consideration of food intake, because to mimic how is it being taken under normal circumstance for normal patients, right? So to reflect that, so we have to design the BE study which reflects the actual condition, right? So it's normally at the fed state as well. Sometimes you even need the steady state, so you can see it's a multiple dose study as well. So for all this, these are the more complicated type of protocols that you actually need to develop. Okay. So going back to the standardization of the diet and fluid intake, so you can see it's actually quite similar across the board, whereby no food for 4 hours post-dose and things like that. So sometimes it's a little bit different, just very, very minor difference. So so some will say start recommendation for 30 minutes prior to administration of product. So this is for fed state. Right, so every meal should be standardized and repeated the same every day, right? But normally we can have some variation as long as the calorie intake is all standardized. So again, everyone says that you must standardize your meal and your water intake, right? So this is a chart which is tabulated by this particular paper, so where they compare the guidelines differences between the three main players in the world, right? So the US, the Europe, and the Canada one. So you can see that the main variation that we can look at is probably at the volunteer section, right? And also the sampling points. So at the volunteer, so as long as it's enough, that's fine. Europe says you need at least 12, or Canada say you need at least 80% power of acceptance for the criteria. So you can see the difference about here on the sampling point, which will be discussed later on as well in the second section of the whole video. So you can see it's about 12 to 18 samples that we need to take. More samples at the Tmax, up to 3 or more half-life that you need to continue the study until. So European says that you need at least 2 samples before the Tmax, right? 3 to 4 towards the plateau phase, and again an overall 12 to 18 samples per dose, per subject per dose. So now let's move on officially into the sampling section. So as mentioned, you need to be at least 12 to 18. So there's quite a lot of samples to be taken actually throughout the whole study. But bear in mind, the samples are not be taken during like one day, because it's a study for at least 48 hours. So it's quite spaced out. So ethical reasons, obviously we won't be booking the same person for so many times. So you have to have some nurse or doctor's involvement as well to actually set up the line, right, so that they can just draw the blood accordingly. So the 12 or 18 samples, again, you expect there'll be one dose to be before the dose, so before the drug is administrated. So to get the pre, so it's supposedly at 0, right, and then it goes up. Right, and you need to have more sampling time during the Tmax or Cmax, so you need to have an estimation of roughly when that would be, so that your graph will look nicely. So no matter how, we try to design all this to fit in nicely so that we can get a nice graph, right, so that the report can be accepted. To allow the calculations of pharmacokinetic parameters. And again, to re-emphasize, it must be well planned, because we cannot repeat the study anymore. So for example, if you really miss the Tmax or Cmax, oh, that's a big issue then, because your graph would be, it won't be pretty at all. So in case it may be rejected, right? So when we look into the guideline, it says that principally blood samples should be used. If we have no option, we may need to use urine samples, but later we'll talk more details into it, because obviously it's more difficult to standardize, because most likely you might need to standardize the fluid intake as well to get a more standardized urine sample. So the main parameters that we need to measure out of the samples is about your Cmax, your AUC, your Tmax. These are the 3 main parameters. So the AUC should at least cover 80% of the whole graph if extrapolated to infinity. So in this video, we actually would not talk about the details on how to calculate. So that will be covered in different modules of the topic. Right, so the sampling schedule should be carried out over a full 24-hour cycle. So because of the circadian rhythm, so because there's different slightly higher or lower metabolism rate and so on throughout the day, so the study will at least need to be 24 hours. So you can imagine the people who are involved in the blood drawing, the phlebotomist has to be there standby throughout the whole study. So literally you have to camp in the clinical site. Right, including the study coordinator as well, together with the participants. It's like a camping session. So the implication of the whole time point is that you can realize that the protocol is very, very extensive, that you need to actually take note of all the timing of all the activities that you do. So for example, the time point that you need, which is like at 0 time point, 1 hour, 2 hours, 4 hours, 6 hours, depends, right? And also the preparation time, because bear in mind we don't really have so many people in a way. So like for example, there's 12 people, you might just have 4 phlebotomists. So one person who draw the blood has to do it for multiple people, but you need to make sure that the time is sufficient for the person to run around, to store the samples and so on. And also the preparation time for the medication and all, there's enough time to store in the correct condition and everything. So all the time point has to be written in the protocol and on the actual sheet on that day as well, and who did it at this time, and give it a sign off. So it's very, very busy. So the person must be very familiar with the protocols before the start of the study. So moving on to the other parts of the guideline, so which states that the AUC, so we normally truncate it at 72 hours, right? If it's too long in a way, because there are some drugs with a very, very, very long half-life. Okay, so it's not really necessary to go to measure beyond 72 hours. So this is one of the sample of data that we try and we hope that we can get by the end of the study when we actually look at the data and analyze it. So you can see there's a tablet, so different forms. So one is the reference, one is the tested, not yet generic drug. So it's about the same dose, of course, and we try to see and to get the curve accordingly so that we can get information such as Cmax, Tmax, and also the AUC, which is the area under the curve, on the total exposure and absorption of the whole drug, of the tablet that the person has taken. So you can see there's more time points on the top near the Cmax and Tmax that hopefully you'll get, and over here you don't really need to measure or take so many samples later on, right? So again, using previously reported papers as a guide is a good idea as well. Okay. So there's different scenarios. For example, when we look at the guidelines, such as on the modified release ones, so we may need to do something called a multiple dose study. So the pre-dose of the sample should be taken immediately within 5 minutes again, and then the last sample is to take within 10 minutes of the nominal time. So again, this is something that you can look at the examples of protocol for better understanding. The second part is on endogenous substance, which is also a bit tricky in a way, because there's different people of at different time point might have different level of secretion, baseline secretion of certain hormones, for example. So imagine it's going to be a nightmare, isn't it, if you're looking at for example hormonal stuff, like for girls especially, right? So if it's hormonal stuff like, you know, or contraceptive and things like that, so obviously it has to be done in girls, for example. You cannot ask a man to take it, right? So and the different part of menstrual cycle, so imagine the level will be different everywhere. So it's not so easy to get everyone to be at the same time frame as well. So there's a lot of considerations that you need to do before when doing the recruitment, and also during the sampling, so you can measure some of the levels first, and to see after that, so how fast is the increase of the certain hormones that the drug that based on the drug, right? The increase of it based on the drug. Okay, so the last part that we look at is on the urine samples. So it's a bit tricky because there could be higher risk of contamination and things like that. So you actually need to measure it also no less than 3 times of the terminal elimination half-life. So again, we try to inline similar with the plasma one. So it does not need to be more than 72 hours, but you can imagine to hit the first criteria of the 3 times of the terminal half-life, you most likely will be a longer study, isn't it? Because we already know that the blood will be a faster reflection on the amount of drug in the body, right, rather than the urine, because it needs to go through the metabolism and elimination to allow it to be out in the urine, right? So it's a longer time frame, so you might need to collect the samples a bit longer during the time as well, right? So maybe you might need to control the water intake so that the variability is not so huge as well, right? So to make it simple, we try to stick to the simple, easier one, which is the blood samples. Okay, so again, we only use it as a surrogate, right? So there's other considerations as listed here too. Okay, last but not least is the take-home message on the sampling time section. It's the last slide. So first, the time depends on what you're looking at. So whether it's a modified release, multiple dose, single dose, the simple ones, right? So you affect the whole planning and of the whole protocol. The second point is on the tubing and the collection form. So these are all the small times that we might miss it, right? If it's if we are still a newbie in developing the protocol for the sampling time. So we actually need to state when we collect each sample, obviously on the drug tubing, right? Because there's different people, different drug tubing. We need to minimize all the confusion or mess up that we might get later on. So when is the tube actually enter the fridge? So it has to be stated as well. When is it, because in the clinical setting you might keep it in a small fridge or a small carrier box, then into the fridge, then we have to transport it to the bioanalytical site. So all the time points, so in a bioanalytical site, when the tube is out for measurement of analysis of the sample, it has to be stated as well to make sure that it's not too long outside and things like that. So there's a lot of recording of time points actually. Besides the actual time point that during the studies as well, when we do it, to say which time point what person takes what. Okay, so you need to take into account of the timing, so to make sure there's sufficient time to do all the steps that you need. As mentioned earlier on, the phlebotomists, they have time to run around from one person to another. So imagine if in a protocol you might need to have 3 or 4 sets of the time points to allow the phlebotomist to run around to get patient number 1 and then to go finish the sample taking, recording, then to go to patient number 2 and so on and so forth. And there's no clashing of time point. Okay, so you have to label very clear in the protocol to know what, to make sure there's no confusion, right? So the person know exactly when to do what. So that's the whole thing that you need to answer. And again, you have to tailor make your whole time frame, right? Okay, so thanks a lot for watching. So if you like the video, do subscribe to the channel if you like and give it a thumbs up and turn on the bell. Thank you.